What I would like to show you this morning briefly is my view of open lung, of the open lung concept and open lung management. And I have chosen for a few slides, and I will also show you exactly 10 minutes video clip in which you can follow what we are doing under for recruitment procedure. Our general rules, can you switch off this slide here? The general rules of our mechanical ventilation, as you see here, very simple: open up the lung, keep the lung open. And now it comes very important: maintain optimal gas exchange with the smallest possible pressure amplitude to avoid shear forces at the lowest possible mean airway pressure, because the mean airway pressure leads to cardiac or hemodynamic depression. And in the procedure, the first thing is, of course, to prevent expiratory collapse in recruitable alveoli. First requires a sufficient amount of PEEP. And normally, all of our patients are a little bit hypovolemic, and you have to guarantee that the patient is in a very good high volumic state. And there are two possibilities to apply the right PEEP level. The first, and the simplest one, is just apply the static PEEP, which is required to keep all alveoli open. And in only pressure-controlled mode, there's another possibility that you choose a time which is too short, that the alveoli get a chance to collapse, and this creates a so-called auto PEEP. And we are in favor, a little bit, especially in restrictive lung diseases, to apply this auto PEEP, because applying auto PEEP, you can much easier control the CO2 elimination. And to avoid hemodynamic deterioration, the recruitment procedure should never exceed 10 to 15 seconds. This is also a very important statement. If the recruitable areas are not completely open, repeat the maneuver after 1, 2, 3 minutes again. And the lung recruitment maneuver in our hands is monitored by arterial oxygen tension, and the efficacy of ventilation is controlled by CO2 elimination, and we measure the CO2 minute production. And here you see what we are doing. If we have a patient, we do not know how much atelectasis are present. We increase the pressure as long as the arterial oxygen tension increases. If we increase the pressure more and arterial oxygen tension doesn't improve further, then we know we cannot recruit more. Then we go down with the pressure to the point where the first deterioration of blood gases appears. That means some atelectasis appears. We keep this pressure in mind and do another recruitment maneuver and keep the pressures then 1-2 centimeters above the level at which we recognize some deterioration in blood gases. And this we do with the upper and lower pressure limit. And now comes this video. This is exact 10 minutes, and then I have still a few words.
Hi, it's John in the SICU. I'm the resident on call. I needed to talk with you about the trauma patient that came in last night. You probably remember him. He's the guy with the hunting accident.
Yes?
Yeah, well, we thought we did a good job of stabilizing him and getting him on the right course, but early this morning he started going downhill. Can I take a minute to review the situation?
Okay.
He's a 42-year-old male, 80 kilos, severe trauma to the thorax, and today's the second day on mechanical ventilation. Right now he's on volume control with a PEEP of 11 centimeters of water, plateau pressure 26, and his respiratory rate is 32. Tidal volume is about 480. That's 6 cc's per kilo. His I/E ratio is 1:2. And since the slide this morning, we had to go up on his FiO2 to 70%.
Mm-hmm.
His gases are a pH of 726. He's slightly hypercapnic with a PCO2 of 48. And his PO2 is 70, his pulse ox is about 90%, and his CO2 minute of production is 420 cc's a minute. He appeared hemodynamically stable when we first attempted the recruitment maneuver this morning. But unfortunately we ran into some problems. When we brought his PEEP up to 20, his blood pressure dropped to 95/65. So we backed off on the PEEP and set him up on a liter of crystalloids.
Okay, that's good.
We gave that over about an hour, and that was finished at 10 in the morning. Since then, we've challenged him with a PEEP of 20, and he tolerated it well this time. His blood pressure dropped to drop it a little to about 118/85, and then we backed off on the PEEP to 11. And we've been holding there until I could get a hold of you. That was about 30 minutes ago, and right now his blood pressures are running about 110/75, and his EKG is normal. I think he may be able to handle the recruitment maneuver again, but I wanted to touch bases with you on the phone to get a little help.
Okay, I understand your problems. What I would recommend is the following. Please switch over the ventilator settings to pressure control. Put the oxygen concentration on 100%. Increase the IE ratio to 2:1. Increase the frequency to 40. And keep the peak pressure at 26 centimeters of water.
Okay, we've done that.
Okay, then just wait 20-30 seconds and please tell me what does the saturation reads and what is going on with the arterial oxygen tension.
Okay, his saturation is up to 100%, and his PO2 is 140.
Okay, considering that we are ventilating our patient with 100% oxygen, we have to realize that the lung of this patient is quite atelectatic. That's why I would like to do a recruitment procedure. Please increase the peak pressure to 45 centimeters of water, but only for 3 breaths.
3 breaths, okay.
The whole procedure should not last longer than 5 to maximum 10 to 15 seconds. And then go back to 30 centimeters of water, wait a few seconds, and then please tell me the figures for the arterial oxygen tension.
Okay, we've done that, and now the PO2 is 265.
Okay, that means we recruited quite a lot of atelectatic lung tissue, but according to our knowledge, it's not fully recruited the lung. That means I would recommend that you increase the peak pressure now, again, please, only for 3 breaths, to 50 centimeters of water, and then go immediately back to 30 centimeters of water.
Okay, 3 breaths at 50 and then down to back to 30?
Yes. What is the arterial oxygen tension doing?
The PO2 has gone up to 390 and the PCO2 is 28.
Almost now, we got almost an open lung, but as I told you before, we can, I guess, still recruit more. That means what we should do once again, go up with the peak pressure again for just 2-3 breaths to 50 centimeters of water, and then go back to 30 centimeters again.
Okay, we're repeating, back up to 50 and, for 3 breaths and down to 30 for 2 after that.
What is the PO2 now doing?
The PO2 is now 530.
Wonderful, wonderful. Now we really have an open lung. The next step, what we should do is, we should look for the lowest possible pressure which keeps our lungs open. And for this, you have to decrease the peak pressure from 30 now to 28 centimeters of water.
Okay, we're dropping to 28.
What is the PO2 doing?
It's remained the same.
Okay, then go down to 26 centimeters of water.
Down to 26.
What is the PO2 doing?
Still the same.
Wonderful. Go down to 25 centimeters of water.
25. Still unchanged.
Okay, then go down to 24 centimeters of water. Now I guess the lung starts slowly to de-recruit. Can you tell me what is going on with 24, with the PO2?
The PO2 is unchanged still.
Wonderful. Then go down to 23.
23.
What is the PO2 doing?
It's dropped to 480.
Okay, that means now we reach the point where the first lung tissue starts to collapse again. That means our lowest possible upper pressure, which we really need for this patient, is 24 centimeters of water. Please do a recruitment maneuver again. Go up to 55 centimeters of water for 3 to 4 breaths, and then go down to 24 centimeters of water.
So up to 55 and down to 24.
Yes?
Now the PO2 is 542.
Wonderful. That means now we found for this patient, for our patient, our lowest upper pressure limit. The next point which we have to do is to search for the lowest PEEP level. Please decrease the PEEP, which should be still 20, to 18 centimeters of water, but keep the peak pressure at 24 centimeters of water.
Okay, we're dropping PEEP to 18.
What is the PO2 doing?
The PO2 is unchanged.
Wonderful. Go down to 17.
Down to 17.
What is the PO2 doing?
541.
Still the same. Okay, then go down to 16 centimeters of water.
Now the PO2 has dropped to 470.
Okay, that means we know now that we at least need 17 centimeters of water to keep the lung open. Now we have to increase the PEEP level once again to 17 centimeters of water and do another recruitment maneuver at 55 centimeters of water.
Okay, so we're doing PEEP to 17 and another recruitment maneuver at 55.
Yes?
The PO2 has increased again to 544, and we have a tidal volume of 410, and the CO2 elimination is 590.
Wonderful. Please realize now that our driving pressure amplitude, which we have an almost sufficient gas exchange, perfect gas exchange, is now only 7 centimeters of water. And still the patient with a driving pressure amplitude of 7 centimeters of water, or about 5 milliliter per kilogram body weight, is still slightly hyperventilated.
Okay, and now in the next few minutes on the movie, you will see that we change a little bit the ventilator setting in the direction that we increase a little bit the PEEP level to decrease the pressure amplitude, and then we even increase a little bit the respiratory rate to get a little bit more auto PEEP and a little bit more dead space ventilation, and finally the patient has a CO2 of 34 millimeter of mercury. Now finally I'd like to show you a patient with a CT. Look at the time, 11:35:55. This picture is taken at a pressure of 35. 20 seconds later at 50, people are not happy with this region here. The pressure goes up to 65. Now everything is gone 1 minute later. And at pressure now 5 centimeters lower than as I showed you initially, you have a totally open lung 1/2 minutes later. And here's an online recording from arterial blood gases. As you can see here, before recruitment, the patient was ventilated with 100% oxygen, with peak pressure 29, PEEP total 10. Then a recruitment maneuver with 65. PO2 increased almost to 600 millimeter of mercury. Then the pressure was decreased, FiO2 was decreased, and finally the patient was ventilated with a peak pressure of 28, 20/22, that means a pressure amplitude of 6 centimeters of water, however, with a respiratory rate of 70, and this resulted in a very normal CO2 elimination. And 5 hours later, this pressure went down already to 26 centimeters of water. And maybe finally, this is in the future, we will not write anymore maybe pressure volume diagrams. Maybe in the future, we will write some pressure arterial oxygen tension diagrams. This is from a patient, from a young child who was nearly drowning, and you see at the pressure peak of 12, peak pressure of 22, arterial oxygen tension was very low. After recruitment maneuver, up to 55 centimeters of water, you can see here now the PO2 increased dramatically, and the pressures, now the peak level could be reduced to 7 centimeters of water, and the peak pressures could be reduced to 17 centimeters of water, and a dramatic improvement of arterial oxygen tension. So let me conclude. If accidentally or on purpose the patient was disconnected from the ventilator, one always has to make a new recruitment maneuver, and suctioning or bronchoscopic intervention should only be undertaken when there's a really strong medical indication. In my last slide, I guess this is a really take-home message, that you realize that the lung of each patient requires different opening pressures and different pressures to keep the lung open, and both of these pressures will change over time according to the disease stage of each individual lung. Thank you very much.